Welcome, everybody. We may have a few more participants join us throughout. I'm joined tonight by Dr. Donnelly in radiation oncology.
Hello, everyone.
And I have to apologize, I'm not very technologically savvy, so this will be a feat. Here we go. Can everybody see this now?
Yes.
Okay, great. So tonight, Dr. Donnelly and I are going to talk about advancements in the management of cervical cancer and vulvar cancer. We have some slides prepared, and I know that I've been saying to use the chat function throughout. Certainly use the chat function to give us questions for the breakout session, but we do want to save a couple minutes. This is a little bit of a cozier chat room since there's just a few of us here. So we would like to have people take off their videos if they, or you can show your videos if you feel comfortable. And at the end, we'll open up to some questions so that we can talk together. And so I just want to start off by giving a small overview of cervical cancer, and I'm going to focus a lot on cervical cancer. However, this also does apply to vulvar cancer. And a lot of our advancements in cervical cancer are advancements that we apply to the treatment and management of vulvar cancer. So while I'm saving cervical cancer, a lot of this does apply to our vulvar cancer patients as well. So cervical cancer is a cancer that arises in the cervix, which is the opening of the uterus, and all women are at risk of cervical cancer. If you have a cervix, you are at risk. It is the fourth most common cancer in women worldwide. And it is globally the second leading cause of death from cancer for women. More recently, we have learned that 99% of cases are caused by a human papillomavirus infection. HPV is an infection that all women and men get in their lifetime if they are sexually active. And there are just certain strains of the HPV virus that can cause cancer. And so as we've learned more about that, we've learned about the way in which the cervical cancer cells become cancer. And it's actually led to developments in vaccines to prevent cervical cancer, as well as started to inform some of our treatment and potential future clinical trials and management of cervical cancer. Pap smear testing is important for early detection of precancer and early stage cancers, and has really been responsible for the decline in cervical cancer rates and death over the past few decades, but it doesn't prevent cervical cancer from developing. And so the development of vaccines, such as Gardasil, are important for the prevention of cervical cancer. And there is data to suggest that if we were to vaccinate globally and worldwide, we could actually eradicate cervical cancer. This picture at the bottom of the slide just shows a little bit about how normal cervical cancer or cervix tissue becomes infected with HPV. It's HPV infections that are long lasting, which cause cervical cancer and cause changes in the cervical cells that over time, if untreated and unrecognized, can become invasive cancer. You can see that along this line, prophylactic vaccines can prevent HPV infection. We're now doing clinical trials to try to find therapeutic vaccines, kind of giving a vaccine after diagnosis of HPV, actually reverse or prevent further dysplasia or precancerous changes from happening. And then in terms of once it becomes invasive cervical cancer, can we target the HPV virus or use other immunotherapy or other mechanisms to overcome the invasive cancer? When we talk about the management of cervical cancer, then it really is a multimodality approach. And the way in which we treat cervical cancer depends on the stage and incorporates a huge team, which is why I invited Dr. Donnelly to be part of this panel tonight, because it cannot happen. We cannot treat women with cervical cancer or vulvar cancer without a multimodality approach that includes surgery, radiation, chemotherapy, and immunotherapy. And even though you see here that early stage 1 surgery may be the only treatment that a patient needs, there are times when radiation or chemotherapy is needed after surgery in order to provide curative intent treatment. And so this multidisciplinary approach to the treatment of cervical cancer is critical and crucial. So as a gynecologic oncologist, the main role in my treatment of, my main role in the treatment of cervical cancer is surgical approaches and learning about and applying novel chemotherapeutics and immunotherapy and molecular targeted therapy for women diagnosed with cervical cancer. I talk to Dr. Donnelly on a weekly basis, and radiation oncology is a critical piece in managing patients with cervical cancer. And so he'll speak to you a little bit tonight on the improved technology to help lead to curative intent treatments, as well as improving the quality of life for women that we've treated with cervical and vulvar cancer before. So to talk a little bit about the updates in surgical management of cervical and vulvar cancer, I just want to spend a little bit of time talking about how surgery in cervical and vulvar cancer has evolved more recently. And you may have heard reports in the news and seen things more recently about cervical cancer and surgery and routes of surgery and how it may be impacting patients both in the past as well as in the future. And surgery for both cervical cancer and vulvar cancer is a critical role in early stage disease. And so you can see in this picture in the corner here for cervical cancer, when I say early stage disease, that's really a stage 1 disease that's confined to the cervix, where we can remove all of the cancer at the time of surgery. If the cancer has already spread outside of the cervix, either into the vagina or the tissues next to it, that's when I'm on the phone with Dr. Donnelly and radiation is playing the role in curative intent treatment for women. So when we are talking about surgery, it is the first step in treatment. It also gives us the stage of the cancer. And then the outcome of surgery, or the pathology that we get, that we receive with a hysterectomy, determines the need for additional treatment, whether it's chemotherapy or radiation. Sometimes we do surgery with the goal of improving symptoms, and then we always want to balance quality of life. So sometimes we may opt for radiation if we think that surgery would be too aggressive or result in too many complications, lasting or resulting in a decrease in quality of life. So we're balancing both curative intent as well as maintaining quality of life for women. So when we do surgery for cervical cancer, we do a radical hysterectomy with lymph node assessment. And so what a radical hysterectomy is removing some additional tissue around the cervix and also some tissue at the top of the vagina. You can see here there's 2 other pictures of just a total hysterectomy or a total hysterectomy with removal of the ovaries and fallopian tubes. And the dotted line under total hysterectomy really hugs the contours or the outline of the uterus and the cervix. And so in a total hysterectomy that we're not performing for cervical cancer, we really don't take much tissue around the cervix. But in a radical hysterectomy, the goal is to remove not only the cancer that's in the cervix, but also make certain that there's no cancer in the nearby tissue. So we remove the tissue next to the cervix as well as the top of the vagina. Now, balancing that quality of life piece, we got really excited when we learned how to do laparoscopic surgery, and we could then send women home the same day, do these surgeries through small, tiny incisions, and we really felt like we were doing a good job for women in terms of doing a big surgery, but also helping them recover faster from surgery. And then in 2018, we actually put the brakes on that, and there was a large clinical trial that came out, and it was published in 2018, where they had randomized women with cervical cancer who were candidates for surgery to either a laparoscopic surgery or an open surgery. And an open surgery is where you make a bigger incision, either a bikini cut or an up and down incision underneath the belly button. And they actually found in this study that women had overall survival improvement or lived longer if they had an open surgery. And so this was counterintuitive to what we thought. We thought if we did a lesser surgery, patients recovered faster, that they would return to their normal life and have the same cancer outcome as somebody that we did a bigger surgery on that stayed longer in the hospital. But we actually learned in 2018 that in some cases it's still better to do an open incision so that we can help women survive longer from their cervical cancer. And when we talk about overall survival, we're still talking about 99% at 3 years. So they found that 99% at 3 years was with open incision versus 94% at 3 years with women who'd had the minimally invasive. But based on that, it's too important when we're talking about cure to overlook this data. And so now we do all surgeries for cervical cancer with an open approach. The other piece is sentinel lymph node mapping. So a big part of cervical cancer surgery is evaluation of the lymph nodes and making certain that when we do this big surgery and we remove the cervix, that there aren't any tiny microscopic cancer cells that have spread to the lymph nodes. Historically, we used to do lymph node removal of all the lymph nodes in the pelvis as well as higher up in the body, but that was associated and is still associated with a higher risk of lymphedema or swelling in the legs of about 20%. 1 in 5 women that we would remove these full lymph nodes on would develop lifelong lymphedema. But in 2018, we had some randomized controlled trials that looked at comparing full lymph node dissection with a technique called sentinel lymph node mapping, where you can see here some blue dye is injected into the cervix, and then the blue dye follows the little channel to the very first lymph node that drains the cervix. And we learned that we could just remove that one sentinel lymph node and get the information that we needed in terms of the cancer stage. And so to do this, we inject dye into the cervix. We locate these blue dye lymph nodes during the surgery, and we allow women to then have a better quality of life after surgery, so that while still getting the cancer information that we need. So the benefits of sentinel lymph nodes now is decreased complications, less leg swelling, less risk of infection postoperatively, and a faster recovery, as well as a higher detection of micrometastases due to improved staging in the way that the pathologists look at those lymph nodes. I'm going to take a 180 now and go from surgery and talk about some updates in treatment of cervical and vulvar cancer in terms of systemic treatment. In women who are not candidates for surgery or have metastatic disease or the cancer has come back after initial treatment, chemotherapy is really the backbone of treatment for these women. The chemotherapy that we use is from a study that the last large randomized controlled trial that we had in cervical cancer, which was published in 2014, and showed us that carboplatin or cisplatin in combination with paclitaxel and bevacizumab is the best chemotherapy regimen that we have for women with metastatic or recurrent cervical and vulvar cancers. If women progress after this treatment, then second-line treatments include single-agent chemotherapy, immunotherapy, and targeted therapy, but unfortunately, most treatment at that point is not curative in intent and gives not significant benefit after a first-line treatment, and so we must do better. The good news is that with the help of clinical trials, we are doing better. And many of you may have heard about cancer immunotherapy. And if any of my patients are here and have heard me talk about immunotherapy, it really is the future of treatment for cervical cancer and vulvar cancer. And what immunotherapy does is it allows your own immune cells to attack cancer cells. The immune cell is made to attack things that are foreign to our bodies. However, there are times when cancer figures out how to hide from the immune system. And what immunotherapy does, and has been studied in other cancer types, is it boosts the immune system, or kind of pulls the blanket off of cancer cells so that our own immune system can attack those foreign cancer cells. We know that in lung cancer and in melanoma, immunotherapy has led to long-lasting curative treatment in women with metastatic disease. And so we've extrapolated from those studies and started pushing our cervical cancer patients to get involved in these basket trials, looking at the studies of immunotherapy. And as a result, in 2018, the FDA approved Embryolizimab, which is the FDA-approved immunotherapy for treatment of women with cervical cancer. And it found that in women who had specific targets on their tumor cells, that if these women express these, it's called PD-L1, express these little molecules on their cancer, then immunotherapy can be effective for treatment in these women. And in some women, in about 15% of women who have responses, they have long-lasting durable responses. So this is really a huge leap forward for the management of cervical and vulvar cancer. And it's been, it was 4 years between 2014 and 2018 before we had a new agent for treatment of these women, and we're really excited about it. With this, I'm going to turn it over to Dr. Donnelly, who's going to talk a little bit about radiation and then also talk about some clinical trials in which we're using immunotherapy in combination with radiation to treat cervical and vulvar cancer.
Thank you, Dr. Strohl. As she was saying, this is very much a multidisciplinary approach for these patients because kind of depending on the stage that these patients present, we may be doing one modality, but very often we're combining a number of different modalities in order to treat these patients. And through that treatment, we see improvement in overall survival, and we've seen improvement in toxicity, a decrease in toxicity for our patients. And as Dr. Strohl alluded to, I'll focus mainly on cervical cancer, but this is very much applicable to the vulvar cancer patients as well, in terms of, especially from the radiation perspective, how these advances in technology have benefited both patient populations. Next slide, please. So within the management of radiation for cervical cancer, as Dr. Strohl was pointing out, typically we get involved when cancer is a little bit more aggressive, a little bit more advanced, and there's typically three components here. There's radiation from the outside, our external radiation. There's internal radiation, where we actually place devices inside the body, either through the cervix into the uterus or via needles into the advanced cancer, so as to accurately treat those areas and avoid normal structures around there. And in combination, as we've been alluding to, chemotherapy plays a role as well. More so here to help the radiation work better, but we're looking at ways in which chemotherapy can be added to that and also afterwards to continue to improve outcomes for patients. And we can see here, through this kind of better treatment, less toxicity, we're having better quality of life and overall survival for our patients. So first here, focused on the external radiation, we have, if you want to move to the next slide, Dr. Strohl. Kind of going back a bit, we see that we've had advances in each of these aspects. It's really external beam radiation that's seen the advances first, because it's the more common modality we utilize, not just for cervical cancer patients, but across the board for our patients. And so when you hear someone talk about radiation, typically they're talking about external radiation. And one of the big advances in the last 5 to 10 years, depending on the disease site, has been the utilization of IMRT. Stands for intensity modulated radiation therapy. And you can see from this picture here, by utilizing different beam energies and angles and these different devices within the machine that can manipulate the beam, we can be very conformal to our treatments and really target in the areas that we want to treat and avoid normal structures. And for cervical cancer patients, that is very important. The cervix sits in kind of intimate relationship to the bladder and to the rectum. So our ability to treat just the cervix and avoid things like the bladder and rectum can have long-term outcomes, long-term benefits to our patients. And we actually looked at a study recently where we asked ourselves, well, when we're being, this tight and we're being conformal, are we making sure that one, we're targeting what we need to and the outcomes are just as good? As Dr. Strohl alluded to earlier, when we tried this approach with surgery, maybe we weren't doing a better job. And then also, were the side effects better? Because these structures do sit so close to one another, making sure that we reduce toxicity. And this randomized trial kind of showed what we all hoped it would, in that we were still having excellent control, but we were improving toxicity, decreased bowel toxicity, decreased bladder toxicity, not just short-term, but long-term too. So for years, patients were doing better afterwards. So it is the norm now that we can kind of move to this conformal technique. In addition to this, we have more technology on our machines that make sure that we're targeting accurately. So we have different devices on the machines that enable us to do kind of rudimentary CTs every day to assess, is everything in the position that we want it to be? And then if we need to, make millimeter movements to make sure that we're coming off the bladder, make sure we're coming off the bowel. And even now, we're continuing to adapt new strategies. We're in the process right now of bringing in an MRI-based LINAC. So every day we're getting an MRI to kind of assess how things are moving, and then moving our plan to kind of follow that movement. If you want to move to the next slide. So as I said, those advances in external beam radiation have been going on for a while. And now we're kind of making some additional advances in terms of the internal radiation, which is probably one of the most important portions of this treatment. Next slide, please. So for internal treatments, commonly referred to as brachytherapy, what we're trying to do is put a device inside the cervix so we can deliver a high dose of radiation internally, kind of right where we want that dose to go. And then that radiation dose actually falls off so quickly that normal structures right adjacent to that, like the bladder and the rectum, get lower doses. And by utilizing these imaging modalities that I've talked about, we're now utilizing MRIs as part of our treatment so we can place the device on the day of treatment. And once it's placed, we do an MRI in that position. So that day we can see how has the cancer changed, where do we need to treat, and what areas do we need to avoid, so as we can be as conformal as possible. And in doing so, we can continue to decrease the toxicity for these patients and continue to make sure that we improve control rates for patients. And similar to what we had seen for the patients going through external beam, when we compare this image-guided brachytherapy, we're seeing improvement in survival for patients than what we used to do even 5-10 years ago for patients. And so for chemotherapy, when Dr. Strohl and I are talking on the phone, she says weekly, I say it's more frequently than that, but as we're talking, we're kind of deciding what's the best role in chemotherapy for these patients during therapy and then after. Historically, it's been cisplatin as the backbone for the therapy in these patients. But we have some ongoing clinical trials that are looking at adding different chemotherapeutics to improve the outcomes. The cisplatin, as I said, its main role is as a radiosensitizer. So it's really helping the cancer cells become more sensitive to the radiation so that I can deliver lower doses but still get the same effects as though I gave higher doses. And so the cisplatin does a really good job. And so we started to ask, are there other modalities that we can use to help out with that cisplatin? And for our early stage patients, there's a clinical trial ongoing adding triapine. It acts in a different way to kind of prevent the cancer cells from being able to repair themselves. And so the cancer cells are smart. They know how to kind of work around chemotherapy, around radiation, but if we find different ways to kind of sweep the leg out from underneath them, we're confident that we can improve survival for our patients. And in the advanced stage disease, we're kind of, as Dr. Strohl was alluding to, seeing these great benefits to immunotherapy in the metastatic setting or more advanced setting. And so we're taking that information to earlier stages and saying, well, we're doing well in the earlier stages. Maybe we can do even better with these immunotherapies that are, improving survival for metastatic patients, but also have a very good toxicity profile to them. So that we're not adding more toxicity for maybe a smaller benefit in terms of outcomes. You can see here, this is kind of how this network works, where there's numerous kind of entities kind of playing into this, where we join together to come up with these new clinical trials for patients. And we go to these meetings where we vet all the clinical trials and the information that's gone forward to see what is the clinical trial that we really want to put our kind of all our eggs into one basket for and move forward to see if in a larger patient population, whether we can show that we can really move the needle for these patients in terms of outcomes for them. And so future directions from both a radiation perspective as well as surgery and gynecologic oncology perspective is, improvement in clinical trials, incorporating new and innovative chemotherapies. From a radiation perspective, incorporating radiosensitizers, medications that are typically low toxicity but help the radiation out. So maybe I can continue to lower that dose. Or even radioprotective agents that when I deliver them, that they can actually minimize the toxicity to the bowel or bladder, so that when the patient takes them, they see less toxicity, but still the same exact outcomes. And it's not really helping the radiation works better, it's just minimizing the toxicity associated with that. Improved technology. What we're starting to do is, historically when we've come up with a radiation plan, it's a daily treatment for a number of weeks. It doesn't change much during those weeks. We adapt as things move, but actually looking at it on a daily basis to see how has the cancer continued to shrink, how are things, changing, to every single day doing this plan that typically took days, if not weeks, into a couple hours, where every day we're adapting that plan so the patient is getting the best possible plan that day. Shorter courses. This is something we're kind of moving to across the board from radiation. I mean, I don't wish upon anyone to have to come here every single day for 7-8 weeks. I wish you could be done in a week. I wish you could be done in a day, but obviously sometimes that's not feasible or safe. But we're trying to explore ways in which we can use radiosensitizers or radioprotectors in order to minimize the number of trips people have to utilize to come here. And then also in personalized therapy. Our medical oncology colleagues have done an excellent job with this in other disease sites, in breast cancer, in our GI cancers. it's really starting to become in vogue in our endometrial cancer patients, and now so in our cervical cancer patients, looking at molecular markers that can identify patients who we think are low risk based on older histology parameters or staging that are actually a little bit high risk, and seeing what we can do for them. Likewise, people who are high risk that we can downstage them and give less aggressive therapy for them. And then finally here, an important thing, especially for cervical cancer patients, is we see this real disparity in terms of who's being affected by this. We see this not only in the US, that more patients of color are being affected with worse outcomes, but across the world. When we look at where cervical cancer is really occurring, the US we see some cases, but around the world we see a plethora of cases. And so it's something important we kind of have to keep in mind. How can we best not serve just a certain patient population, but all of those who are being affected by cervical cancer? So I'd seen the warning that we only have a few minutes, but hopefully we can answer some questions before we move on, if there are any.
This is Nicole. If you do have any questions, just remember to unmute yourself or send a message in the chat box.
And I would just put a plug here for, so I know people are hesitant sometimes to ask questions in these situations, but social media has become a really interesting place for questions. I interact with patients there as well, and to kind of see where new trends are going, et cetera. And I know a number of people who are involved here actually have some sort of social media presence, so you can see what's new, when it's evolved. Especially when we go to meetings, I'm usually kind of putting out information about new things we see. So it's an interesting resource to kind of, that we think of for our personal interest, but it's also from an academic perspective, something we can focus on as well.
Yes, absolutely. I think that followed Eric Donnelly on, we should put our Twitter handles on here so everyone can follow. But certainly the communities are important, and not just for the social interaction, but academically, new research is breaking. I remember at Survive and Thrive last year, we were, which is an ovarian cancer conference, one of the European conferences was happening, and people were live tweeting from the conference during the Survive and Thrive conference. And we were sharing new updates on clinical trials. And so nowadays, clinical trials and cancer therapeutics really change every month. And clinical trials can come out, next week and completely change the paradigm of treatment. And so cervical cancer is, it's unfortunately a common cancer for women across the world, but in terms of the amount of dedicated research to it, it's underfunded. And so we do a lot, we take a lot from research that's happening in other cancers and try to apply it to women with cervical cancer. And Dr. Donnelly sits on the NRG cervical cancer committee and is there making decisions about clinical trials. So we're hoping to see those rapid improvements that other cancers have seen more recently.